I just wanted to begin by expanding on what we are talking about this afternoon. The full spectrum of what we're talking about are called paragangliomas, of which phaeochromocytoma is just a part. The phaeochromocytoma is what we have in the adrenal medulla, whereas the lesions we're talking about occur along the entire sympathetic chain, as Dr. Makumbi mentioned, and then the parasympathetic tissue in the head and neck, all of which 5% produce catecholamines. So let's talk in that context if we're talking about paragangliomas. And the surgeon will be talking mainly about the extraadrenal sites, because the adrenal site is very easy to understand. The organ of Zuckerkando is a very important organ at the root of the inferior mesenteric artery, which is a sympathetic ganglion and can also be involved. But sympathetic pressures in the urinary bladder, the kidneys and the heart, and also in the mediastinum can be involved. This is very important because most of the times we know we are looking at adrenal medulla, but more than 50% are occurring elsewhere. Uganda, we expect to have between 70 and 280 patients if we go by the prevalence that has been talked about. But as you can see, over a number of years, we only have 28 who have been recorded in Mulago. I'm sure Jinja, Mbale, and other hospitals don't handle these patients. So where are the others? If you have 28 in so many years, where are the others? I think they have been buried a long while ago. And if we have 280 of these patients in Uganda, then we need to work hard and pick them. Those have already been talked about. I'll not go into this. You have the slides and you read them. But just to mention that a lot of work has been done on these mitochondrial genes, from which arise mutations along the enzyme that converts succinate to fumarate in the Krebs cycle. This has been talked about. But what is important is just remember that if a patient presents with hypertension, particularly resistant hypertension, look for those three and you'll be that sensitive and that specific to it. Sometimes you also have what we call a clinical suspicion. The radiologist will tell you about incidental findings of adrenal tumors. I think sometimes the radiologists are the first people to come across these patients. They are doing a CT scan for other reasons, and here they find an incidental tumor, and then we work backwards. But many of these incidental tumors don't have active disease, but some of them can be picked up. I think this has been discussed. Just to mention that these headaches last about an hour. They're associated with the pallor or nausea. Sometimes they persist for about a week. Now, these tumors secrete either noradrenaline, adrenaline, or dopamine. But if you see more of these, you know you're talking about epinephrine. These patients tend to have increased total peripheral resistance, and the heart rate tends to go up. These are important things when you are managing them. One of the important things to remember is that they have a labile BP, so sometimes the BPs are low, sometimes they are normal, and sometimes they are high. These occur within the same day, depending on when the catecholamines are being released. They also have impaired sympathetic reflexes, and they have unrecognized chronic volume depletion. And again, before you go to theater, you must make sure that you've corrected that. Of course, phaeochromocytoma ends up being a cardiovascular disease, and I remember the previous presenter was saying that our patients are older. Part of the reason is because we diagnose them late. So they are walking around, happening to live around a little longer, and then we pretend that our patients are older. Actually, it's just that we are diagnosing them late. And because of this, many of them come up with these kind of cardiovascular complications or findings. We need to talk about the differential diagnosis. It is very wide. And of course, I know the story of a patient who was before a counseling session and had phaeochromocytoma. Nobody knew that this patient had phaeochromocytoma. And the counselor kept complaining that this patient doesn't concentrate. You are talking this, is moving up and down, he's sweating. You tell him something, and so the counselor was counseling a phaeochromocytoma patient and nobody knew. But so many other things look like phaeochromocytoma. Something simple like migraine can look like phaeochromocytoma. Or even drugs, as I've mentioned on the slide. Panic attacks. About 10% of people in this room have panic attacks. People with hypoglycemia, mastocytosis, and the carcinoid syndrome are important. Important to talk about precipitants. These are easy, usual things: straining, exercise, abdominal pressure. Of course, there have been lots of stories about abdominal pressure, particularly during the sexual act, when people collapse and they think it was witchcraft. So, it's important to remember back in physiology that the catecholamines are metabolized through metanephrines, and the metanephrines are further metabolized to vanillomandelic acid. So VMA is the end product at the bottom. The metanephrines are the middle products. So the 24-hour urine concentration of these products is actually a very good test, only that we are not yet doing it in Mulago. But I hope that part of the renovations we are doing is to measure 24-hour urine catecholamine secretion. I think some of these figures have been given to you, but in my practice mainly I'm asking for plasma or urinary metanephrines. Now let's not think so much about the fact that we don't do them in Uganda. We are now in an international world, and these tests are being done elsewhere. So you go to our partner labs, the good labs in Kampala. They take the blood out, and within a week you have results. So please, let's stop that story of saying they can't be done in Uganda. We can do them, and many patients are benefiting from these services. However, some tumors are biochemically silent. And again, the surgeons will tell you they have removed very big tumors which didn't have much of hormones. Somebody asked the question before, does tumor size correlate with hormones? Actually, no. In endocrinology, things can be so small, like me, and mean so much. Now, we need to continue. I know the radiologists are going to talk about localization of the tumor, but I wanted to mention one specific investigation in nuclear medicine, which is arguably the best in terms of localizing the tumor and in terms of showing us the functionality of this tumor, which is even far better and more useful than the blood test. Those are the radioisotopes we use, but MIBG is the most important one, but the others can also be useful. This is a patient who had an MIBG. This patient had a head and neck paraganglioma in the right tympanic area. It's a very big tumor that's occurring in the parasympathetic ganglia within the ear. And you can see the CT scan may come out showing maybe some hazy something or something of that sort. But this one shows you a much better whatever. This is the typical case of MIBG of a patient with a unilateral right adrenal tumor. And you can see even a blind person would see this. On the other hand, this is a patient who had a metastatic paraganglioma. You can imagine there is a tumor. You can see all the way from the pelvis, and in the thoracic, you can see tumors elsewhere. Imagine if a surgeon had seen one tumor in adrenal and removed it in such a patient. What would have been the use of that surgery? You know, it becomes very, very problematic, particularly the patients who come back and the pressures don't decrease. Preparative management, we aim to prevent hypertensive crisis, cardiac arrhythmias, pulmonary edema, cardiac ischemia. These will kill the patient immediately. But also hypertensive crisis after tumor removal. And these have been talked about, beginning with the receptor blocking agents, and then going on with the beta blockers. In other countries, they use alpha-methylparatyrosine and others. Just briefly about the severe crisis. This is where a surgeon will not help you, because they will tell you, first control the patient. Surgeons are cowards. So they hand over to us these patients, and for us we struggle with them. It occurs whether in DKA or other things. So phaeochromocytoma crisis is one of the crises in endocrinology. Patients will have profound sweating. In other words, the same symptoms but in a profound way. And of course they are near death. Unlike our colleagues in pediatrics, we prefer to start with phentolamine. But we also can use phenoxybenzamine. This is IV now for the severe crisis. Sodium nitroprusside has also been used, particularly in ICU settings, but with the danger of cyanide toxicity. And then beta blockade later. Some of these tumors are malignant, and the surgeons will tell you more about how they deal with them. But again, where the surgeons become, where they hand over back these patients to us. Surgical debulking of tumor tissue has been studied clinically and in research settings, and so has been found to be useful. But in the palliative care measures, we have used therapeutic iodine-131, which is also partially useful. Our oncologists have used those 3 drugs with partial success. External beam irradiation has also been used. For example, that patient who had many tumors in the chest, you can use that, localizing where some tumors are. And also palliation with the alpha-adrenergic blockers and alpha-methylparatyrosine. So this slide belongs to palliative care team. They can find that useful. Dr. Nambia, who is here, will tell you more about therapeutic MIBG. We use MIBG for both diagnosis and also for therapy. And we use beta emission of iodine-131 to treat some of these tumors. This is done really under medical supervision because of the radiation, and the patient has to be isolated in a room for several days. Thank you very much.